Scenario. Today we'll discuss alcohol withdrawal syndrome using Mr. Jackson Sakala's case. Let's start with the basics. What is alcohol withdrawal syndrome?
Alcohol withdrawal syndrome is a cluster of symptoms that occur when a person who has been drinking alcohol heavily for a prolonged period suddenly stops or significantly reduces their intake. It usually starts within a few hours to days after the last drink and can range from mild symptoms to life-threatening conditions like delirium tremens.
Good. What are the risk factors that make someone more likely to develop withdrawal symptoms?
The main risk factors include chronic heavy alcohol use, like in Mr. Sakala's case, 10 years of excessive alcohol consumption. Previous episodes of withdrawal, he had an admission for alcohol-related issues last year. Older age and coexisting medical conditions, he is hypertensive. Not eating well or having nutritional deficiencies, common in alcoholics.
Well said. Now, withdrawal syndromes are classified based on severity. Can you break them down?
Sure, there are 4 main categories. 1. Minor withdrawal, 6 to 48 hours after last drink, nausea, vomiting, tremors, shakiness, weakness, irritability, anxiety, insomnia. 2. Major withdrawal, 24 to 72 hours after last drink, lasting up to 10 days, more intense tremors, heart palpitations, elevated BP. Hallucinations, visual, auditory, tactile, mood swings. 3. Withdrawal seizures, 6 to 72 hours after last drink, generalized tonic-clonic seizures, hallucinations, fever, increased BP. 4. Delirium tremens, 2 to 4 days after withdrawal, peak at 3 to 5 days, life-threatening, clouding of consciousness, disorientation, severe hallucinations, fever, diaphoresis, sweating, risk of dehydration and cardiovascular collapse.
Excellent breakdown. Based on this classification, where does Mr. Sakala fit?
Right now, he is not experiencing active withdrawal, but he has a history of alcohol dependence and past hospital admissions, meaning he is at high risk for withdrawal symptoms if he stops drinking suddenly. He needs careful monitoring and possibly medical detoxification.
What investigations would you order to assess his condition?
I would order 1. Full blood count, FBC, check for anemia, infection. 2. Liver function tests, LFTs, assess liver damage from alcohol. 3. Renal function tests, check kidney function and electrolyte imbalances. 4. Blood glucose, rule out hypoglycemia. 5. Chest X-ray, if there's suspicion of infection or aspiration pneumonia. 6. Alcohol use screening tools, audit and cage questionnaires to assess dependence.
Good list. Electrolyte imbalances, especially low potassium, K+, low magnesium, milligrams 2+, and low phosphate, PO4 cubed, are common in alcoholics and increase seizure risk. Now, let's discuss treatment. What's the Shaver's mnemonic?
S. Sedation, benzodiazepines like diazepam, lorazepam, chlordiazepoxide for withdrawal symptoms. H. Hydration, IV fluids or oral hydration. A. Assess for infections, which can worsen delirium. V. Vitamins, thiamine 100 to 400 mg to prevent vernix encephalopathy. A. Electrolytes, correct K+, Mg2+, PO4 cubed imbalances. R. Rehabilitation, reorientation, counseling, Alcoholics Anonymous. S. Support, family and peer support.
Exactly. For Mr. Sakala, what benzodiazepine regimen would you recommend?
If he develops moderate to severe withdrawal, I would use diazepam 20 mg every 6 hours on day 1, then taper down over 7 days, thiamine 100 mg IV or oral for at least 1 month to prevent Werner-Korsakoff syndrome, monitor BP closely since he is hypertensive.
Well thought out. What additional medications could help prevent relapse?
Disulfiram, antabuse, causes unpleasant reactions with alcohol, but requires high motivation. Naltrexone, reduces alcohol cravings, 25-50 mg daily for at least 6 months.
Detox alone isn't enough. What psychosocial interventions would you recommend?
Individual counseling, CBT, to address triggers and stressor. Group therapy, Alcoholics Anonymous, Smart Recovery. Family therapy to educate and involve loved ones. Lifestyle changes, healthy diet, exercise, stress reduction techniques.
Exactly. Last question, what's the main complication we fear in alcoholics if withdrawal is poorly managed?
Delirium tremens, which can lead to seizures, cardiovascular collapse, and death. It's a medical emergency requiring ICU care.
Well done, Scenario. Let's admit Mr. Sakala for observation, start him on vitamins, fluids, and a benzodiazepine taper, and involve their rehabilitation team. What percentage of chronic alcohol users develop alcohol withdrawal syndrome (AWS) after stopping alcohol?
About 50% of chronic heavy drinkers experience withdrawal symptoms when they stop drinking, and 3 to 5% progress to delirium tremens (DTs) if untreated.
What factors increase the risk of severe withdrawal?
Long duration of alcohol use, e.g., Mr. Sakala has been drinking for 10 plus years. High daily alcohol intake, 4 bottles of whiskey, 3 to 4 times a week. Previous withdrawal episodes, he was admitted for AWS last year. Coexisting medical conditions, hypertension. Poor nutrition and vitamin deficiencies, common in alcoholics. Older age, greater than 40 years, increases risk of complications.
What causes withdrawal symptoms at a neurochemical level?
Chronic alcohol use enhances GABA activity, an inhibitory neurotransmitter, and suppresses NMDA, glutamate, receptors. When alcohol is suddenly stopped, GABA activity decreases, right pointing arrow leading to hyperexcitability, anxiety, tremors, seizures. Glutamate activity rebounds, right pointing arrow causing agitation, hallucinations, and autonomic instability.
Why do seizures occur in alcohol withdrawal?
Seizures happen due to glutamate overactivity and GABA underactivity after alcohol cessation. This leads to neuronal hyperexcitability, increasing the risk of generalized tonic-clonic seizures.
What is the timeline of alcohol withdrawal symptoms?
6 to 12 hours, right pointing arrow minor withdrawal, tremors, nausea, anxiety. 24 to 72 hours, right pointing arrow major withdrawal, hallucinations, increased BP, tachycardia. 6 to 72 hours, right pointing arrow withdrawal, seizures, tonic-clonic. 48 to 96 hours, 2 to 4 days, right pointing arrow delirium tremens, confusion, disorientation, hallucinations, autonomic instability.
What is the difference between alcohol withdrawal hallucinosis and delirium tremens, DTS?
Alcohol withdrawal hallucinosis occurs within 24 hours of stopping alcohol, but consciousness remains clear, patient is alert and oriented. Delirium tremens, DTs, occurs 2 to 4 days after stopping alcohol and includes disorientation, confusion, and autonomic instability, life-threatening.
How can we assess the severity of alcohol withdrawal?
Using the Clinical Institute Withdrawal Assessment for Alcohol, CIWA-Ar, score, which evaluates symptoms like nausea and vomiting, tremors, sweating, anxiety, agitation, hallucinations, orientation changes. A score greater than 15 indicates severe withdrawal, requiring benzodiazepine treatment.
What are the main complications of alcohol withdrawal syndrome?
1. Seizures, 6 to 48 hours after last drink. 2. Delirium tremens, DTs, 2 to 4 days post-withdrawal, can be fatal. 3. Wernicke's encephalopathy, due to thiamine deficiency, presenting with confusion, ataxia, and ophthalmoplegia. 4. Korsakoff syndrome, irreversible memory loss due to untreated Wernicke's. 5. Electrolyte imbalances, hypokalemia, hypomagnesemia. 6. Aspiration pneumonia, from vomiting and altered mental status.
What are some differential diagnoses for alcohol withdrawal syndrome?
1. Delirium due to general medical conditions, e.g., infections, metabolic disturbances. 2. Benzodiazepine or barbiturate withdrawal, similar GABAergic withdrawal effects. 3. Acute psychosis, schizophrenia, brief psychotic disorder. 4. Postictal confusion after a seizure disorder.
What are the indications for hospitalization in alcohol withdrawal?
History of withdrawal seizures or DTs, severe withdrawal symptoms, CIWA-Ar greater than 15. Unstable vital signs, elevated BP, tachycardia, fever. Severe electrolyte imbalances, coexisting medical conditions, hypertension, liver disease. Inability to tolerate oral fluids or medications.
Which benzodiazepine regimen would you use for withdrawal management?
For severe withdrawal, diazepam 20 mg PO every 6 hours on day 1, then taper over 5 to 7 days. Lorazepam, if liver disease is present, 1 mg every 6 hours, tapering over 7 days. Clodiazepoxide, long-acting, can also be used. For mild withdrawal, diazepam 10 mg PRN based on CIWA-Ar score.
Why is lorazepam used at times instead of chlordiazepoxide in detoxification?
Lorazepam is preferred over chlordiazepoxide in certain situations during alcohol detoxification due to its pharmacokinetics and metabolism. Here's why. 1. Liver dysfunction or hepatic impairment. Lorazepam is metabolized by conjugation in the liver, making it safer for patients with liver disease, e.g., alcoholic hepatitis, cirrhosis. Chlordiazepoxide is metabolized by the liver's CYP450 system, and its active metabolites can accumulate in liver impairment, leading to excessive sedation and respiratory depression. 2. Faster onset and shorter half-life. Lorazepam has a quicker onset of action, making it more effective for rapid control of agitation and seizures. Chlordiazepoxide has a longer half-life, which can be useful for a smooth taper but poses a risk of oversedation in elderly or frail patients. 3. Parenteral, IV, IM, administration availability. Lorazepam can be given IV or IM, making it useful in patients with severe withdrawal symptoms, e.g., delirium tremens, seizures, who cannot take oral medications. Chlordiazepoxide is only available in oral form, limiting its use in emergency situations. 4. Risk of oversedation in elderly patients. Chlordiazepoxide has long-acting metabolites that can accumulate, increasing the risk of excessive sedation and falls in elderly patients. Lorazepam has a shorter duration, reducing this risk.
Key takeaway: use lorazepam in severe withdrawal, liver disease, elderly patients, or when IV administration is needed. Use chlordiazepoxide in patients with mild to moderate withdrawal who can take oral medications and have no liver impairment for a smoother, longer taper. Why is thiamine supplementation essential in alcohol withdrawal?
Alcoholics are thiamine deficient, putting them at risk for Wernicke's encephalopathy, which can progress to Korsakoff syndrome if untreated. We give thiamine 100-400 mg IV or PO daily for at least 1 month, before giving IV glucose to prevent worsening of Wernicke's.
After withdrawal management, how do we prevent relapse?
1. Pharmacotherapy. Naltrexone 25-50 mg daily, right-pointing arrow reduces alcohol cravings. Disulfiram 250-500 mg daily, right-pointing arrow causes severe reactions if alcohol is consumed. Acamprosate 666 mg TED. Right-pointing arrow helps maintain abstinence. 2. Psychosocial interventions, cognitive behavioral therapy, CBT, to address triggers. Motivational interviewing, ME, to enhance readiness to quit. Group therapy, Alcoholics Anonymous, Smart Recovery. Family therapy for support. 3. Lifestyle modifications, nutritional support to prevent deficiencies, regular exercise to reduce stress and cravings, employment and financial counseling, since alcohol affected his work performance.
What's the most important factor in preventing relapse?
Long-term engagement in therapy and strong social support. Patients who participate in ongoing counseling, peer support groups, and medication-assisted therapy have the best outcomes.
If Mr. Sakala suddenly stops drinking without medical supervision, what is the worst possible outcome?
Delirium tremens, DTs, which can be fatal due to severe autonomic instability, seizures, and cardiovascular collapse. This is why hospitalization and careful withdrawal management are crucial.
Well done, Jackson Sakala. You have a solid grasp of alcohol withdrawal syndrome and its management. Keep up the good work.